A hemi-skull bones model is used in this exercise. The model comes with a foam brain but no other soft tissue, therefore pericranium is simulated with masking tape applied to the skull. Duct, styrofoam shed is used for connective tissue. Duct tape for galea and masking tape again is used to replicate skin. On the left is the hemi-skull with masking tape ready for application. The center photo shows the inside view of the hemi-skull with the foam for cranial contents provided at purchase from Sawbones. The right photo shows the Sawbones after applying masking tape to replicate pericranium and sitting on styrofoam, which is sized for application. As the connective tissue layer. In this slide, the styrofoam is placed and secured with duct tape, which replicates the galea. Then, masking tape is applied to replicate skin. You now have a hemicrania with a scalp. Doing a craniotomy on a saw bone model starts with planning the craniotomy. Place the Sawbones model in an appropriate position for the trainee to make the scalp flap, boreholes and craniotomy. Mark the scalp flap for the traumatic or question mark flap. A full-thickness scalp incision is made along the marked skin. The pericranium tissue is then cut and peeled away. The scalp flap will be retracted to provide adequate exposure to make the burr holes and, subsequently, craniotomy. The hematoma is drained, tack-up sutures are placed, the cranial flap is replaced, and the scalp is closed in layers. The craniotomy incision is planned and marked and then infiltrated with local anesthesia. Full-layer incision is made. The scalp flap is mobilized with periosteal elevator. The scalp flap is retracted with stay sutures. Burr hole sites are identified and pericranium is elevated.
So the first part of the surgery is after positioning the patient, marking our scalp incision. So our scalp incision extends for acute epidural hematoma and for other traumatic conditions. So we will mark it around 1 centimeter anterior to the tragus, and we extend it up posteriorly above the pinna to 8 centimeter posterior, and we will turn up and turn it back to the front around 1 centimeter lateral to the midline, to the level of forehead. I mean just posterior to the hairline. So we will stop there, so we shouldn't cross the hairline. So then after marking our craniotomy flap, then we will infiltrate local anesthetic agent. Then we will draw to make sure that we are inside the vessel. So we are not, and we will continue the same thing, and we will infiltrate to the edge of our scalp marking. After infiltrating the local anesthetic agent, so we will clean the surgical field with antiseptic agents, and then we will drape it in quadrants. So after draping the surgical field, we will continue with a scalp incision. So our scalp incision extends from the around 1 centimeter anterior to the tragus all the way to our marking. So just at the level of temporal part, we will just incise superficially, and our incision to the deep sides will continue with monopolar cautery. So at this side, so at the same time we will continue securing hemostasis with bipolar cautery, and so we pass the superior temporal line, so we can go bone deep incision. So we will incise it to the whole layer of the scalp, and we'll continue securing hemostasis using bipolar cautery. So the part that's at the lower part, we'll use monopolar cautery, but for the demonstration purpose I will use just the surgical blade. So after finishing the incision, so we will try to elevate our scalp flap using pericranial tissue, I mean periosteal elevator. So we'll use this, and so we'll continue elevating the flap. If there is any adherent pericranial tissue, we will use monopolar cautery, and at the same time we will use periosteal elevator to elevate the scalp flap. So we will use either we can use just stay switchers to retract our scalp flap. So we use a rubber band for retraction of the scalp flap. So we will use artery to retract, and so to prevent desiccation, so we will apply wet gauze on the scalp and dry gauze just behind our scalp flap. Here we apply dry gauze and we will apply wet gauze here, and we will retract it with rigid part of our draping. So based on our imaging finding is epidural hematoma, and we have localized the site of epidural hematoma. So we'll continue on. First we will localize our barrel sites, and we will continue drilling those sites. So our epidural hematoma is as of any other common sites of epidural hematoma. It's around frontotemporal area.
The dura is mobilized so that the Gigli saw can be passed using a guide, which can be improvised with IV tubing. The guide is removed after the saw is passed. The burr holes are now joined by cuts from the Gigli saw. TP Resi. T-Oma cranial flap.
We did 4 of the burr holes to connect them to make a cranial traumatic flap of the cranium. So this one is the temporal burr hole, which is the first one that we have to do to decompress the temporal fossa and then the brainstem as soon as possible. And then this is around the frontal, on the frontal lobe, and this one is the parietal, and the 2 on top are the parietal burr holes. So we connect the 4 burr holes to make a skull flap and remove the underlying hematoma. So once we did the 4 burr holes, we just have to dissect the dura from the inner table of the skull. So we use the dural dissector to free the outer layer of the dura from the inner table of the skull. So we just apply a gentle hand movement to dissect the dura free in every direction before applying the Gigli saw. Once we dissect the dura free, we try to pass the Gigli saw from one of the burr holes to the other side. Ideally, we should have a guide which guides the Gigli saw to the other side of the burr hole, but if we don't have a guide, a proper guide, we can use an IV set once we dissect the dura free. So we are using now the IV set to protect the dura from tearing from the Gigli saw. Sometimes we just have to adjust the direction of the Gigli saw tip so that it comes to it comes out on the other side of the burr hole. If you face difficulty, we just have to dissect again free, and if the dissector goes freely in the subdural space, we can also use the dissector as to guide the Gigli saw. So I'm just using that one to pass the Gigli saw from one of the burr holes to the other side. We can also try to go from the other side. And now I can see the tip of the Gigli saw here. And to hold it, we can use the artery forceps and then grab the Gigli and then pull gently. Once the Gigli saw passes, then we remove the IV set protection. And then we'll use a handle or an artery to hold the Gigli saw. And then your assistant will hold the skull tight so that it won't move. Yeah. So you have to make your hands as wide as possible so that the cut of the bone becomes slant. So when we replace it back, so that it fits perfectly where it was. Once we do this, we just have to do all the four corners of the burr hole and then remove the cranial flap. So we just replace the IV set again, and then we again dissect the dura from the inner table of the skull. And then we negotiate the jiggly saw to come out to the next burr hole. And then we'll use arteries again as a handle. Sorry, first we just have to remove the IV set. So the IV set is used as a protection, and once we are in, we can remove the IV set so that we can cut the bone effectively. So the flap is now, we did the craniotomy, and now the flap is free to be removed.
Burr holes have been connected. The cranial flap is removed, the hematoma is evacuated, and the dura is tacked up to the pericranium. The cranial flap is replaced.
So once we connect the burr holes, we are ready to remove the cranial flap. So we just have to do it gently with a dissecting elevator and then a periosteum. While your assistant is elevating the scalp flap, you have to see whether you have to free the dura from the inner table of the skull, and then you just have to use a ronger to hold the skull up, the skull flap up, and then you gently free the skull flap from the underlying dura and hematoma, and then you just remove it. And you place the skull flap in a weight protected area so that it doesn't fall on the ground. Once you remove the skull flap, you will be able to see the hematoma. So the hematoma, you then have to remove the cloth, and you do that with a spatula, a suction, and also after, like, sometimes you can also use a hydrodissection to remove the hematoma. So you gently remove the hematoma with a spatula or a dissecting elevator, and then you also have to use a suction to suck out some of the hematoma. So as you can see, this is the temporal pole, and this is the middle cranial fossa. So it's like going onto the middle cranial skull base. So you just have to remove the hematoma, and once you remove the hematoma, you might be able to see the bleeding from commonly the middle meningeal artery. So you have to follow the middle meningeal artery and then see where the bleeding is, and you just have to cauterize it with a bipolar cautery. And then once you secure hemostasis, you take your time to remove the remaining hematoma gently, and then you will be able to see the dura clear. And then you can also go posterior medial and anterior to remove any remaining hematoma that's underlying the skull. And then when you finish evacuating the hematoma, the next step will be, as you can see, the hematoma has taken a lot of the epidural space, and you can see that there is a very big epidural space. So to obliterate that epidural space and also to control any oozing bleeding, you have to apply tack-up stitches. Tack-up stitches are very important to prevent hematoma recollection. So usually we apply tack-up stitches in between two consecutive burr holes. Here one, here another one, and here the third one, and here the fourth one. And if there is still epidural space, you can apply more tack-up stitches to obliterate the epidural space more. To apply tack-up stitch, we use usually 4O Vicryl. You stitch the dura with the pericranial tissue as demonstrated here. And then you, in a controlled movement, you just taint the dura to the inner table of the skull. You have to apply more than 3 stitches if it is a Vicryl. That's right. As you can see, the epidural space is now narrower than the previous one. Once we finish the tack-up stitches, we again check whether there is any bleeding site. We arrest any bleeding vessels, and then we put back the craniotomy flap. And then we close the scalp layer by layer fashion.
The scalp flap is returned. The galea is closed, then the skin is sutured.
Okay.
So we are going to reapproximate the galea, and then we continue with the scalp skin. This one is not working.
It's so fragile.
ትንሽ ቲክነሱን ጨምሮ እንትይዘው። ኦኬ
What's the right card?
Yeah.
Please record the performance of a craniotomy using the model. Make sure you do everything on the checklist. Assess your performance out of 20.